Hello, my name is Sean Collins. I am a radiation oncologist at MedStar Georgetown University Hospital. I am honored to give this talk on radiation therapy planning using advanced imaging, pearls, and pitfalls. My disclosure is relevant to this talk. I am a paid consultant for Blue Earth Diagnostic Speaker Bureau. And today I'm going to talk about Posluma, which is a new PSMA-specific PET agent for prostate cancer. The two indications are men with suspected metastases who are candidates for initial definitive therapy, and men with suspected recurrence based on an elevated PSA level. Next, I would like to discuss some important safety information. Image interpretation errors can occur with Posluma. A negative image does not rule out the presence of prostate cancer, and a positive image does not confirm the presence of prostate cancer. The performance of Posluma is dependent both on the PSA level and the risk group. Posluma uptake is not specific for cancer and may occur in other cancers and normal tissues. Clinical correlation is recommended. And image interpretation is dependent on the image reader. Misinterpretation is possible in the prostate and the prostate bed region. Consider multidisciplinary consultation and histopathologic confirmation. Posluma is radioactive and may increase the risk of secondary cancers. Patients should hydrate before and after administration and void frequently after administration. Ensure safe handling to minimize exposure to both patients and healthcare workers. Adverse reactions that are reported in greater than 0.4% of patients include diarrhea, high blood pressure, and injection site pain. ADT may alter uptake in prostate cancer, and please report suspected reactions. Also, complete prescribing information is available on this website. So Posluma scans impact staging in intermediate to very high-risk prostate cancer. The higher the risk group, the increased probability of lymph node involvement or bone involvement. This is an example of a Posluma scan and its impact on staging in very high-risk prostate cancer. And if you look at the blue arrow, it shows a local recurrence. But if you look at the red arrows, these are newly identified lymph nodes that were not identified on standard imaging, and this greatly impacts the management of this patient. Also, PSMA scans can impact treatment planning in unfavorable risk patients. So if you look at this MRI, you don't see any evidence of a dominant intraprostatic lesion, but the PSMA glands clearly shows it and allows us to dose escalate to that area, giving a higher chance of eradicating the cancer. Specifically, the PSMA scan was more accurate identifying the recurrence than the MRI was. So PSMA scans can also help us identify lymph nodes that were not identified on conventional imaging. You can see this lymph node here and this lymph node here that were not seen on conventional CT scans. We were able to treat the lymph node beds with standard dose 50.4 gray, but also escalate to the PSMA positive areas to 66 gray, giving us a better chance of eradicating the tumor. Now, if you look at the detection efficacy of Posluma scans for rising PSA after prostatectomy, you can see the detection rate increases with the higher PSA value, with a detection rate of greater than 95% at a PSA value of greater than 2. And what we're detecting is both local recurrences, intrapelvic lymph nodes, extrapelvic lymph nodes, bone metastases, and also visceral metastases. And the rate goes up with higher PSA levels. So as you can see from this, Posluma scans have a great impact on patient management. For example, if you see a lymph node involved or you see a local recurrence, you can increase the dose to the local recurrence or lymph node, and this allows for a higher chance of eradicating the cancer. In some cases, you find lower abdominal lymph nodes, and in those cases, you can expand the upper border of the radiation fields to include those lymph nodes. Unfortunately, in some cases, you find multiple bone metastases, And then you go from a situation where you were doing local radiation treatment to an area where you were just giving systemic therapy. So as you can see that these are major changes in the management that we see from these PSMA scans. And with patients that have PSAs less than 2, you can see that approximately 30% of the patients have major changes in their treatment plan. This is another example of a post-Loomis scan impact on staging in patients with rising PSA post-prostatectomy. If you look at the CT scans, you would think that this person is node negative and does not have a local recurrence. But if you look at the post-Loomis scan, you see an obvious local recurrence and an obvious involved node. We can give this local recurrence 72 gray, and we can give this node 66 gray, improving the chance of eradicating the cancer in this patient. As you can see, PSMA scans made aid in patient-specific design of pelvic radiation treatment volumes. If you look at this first patient, they have increased uptake on their PSMA scan in their left prostatic fossa, which was not seen on conventional imaging. And this allowed us to do radiation dose escalation to that involved area. On the second patient, you can see there's actually an involved perirectal lymph node on the PSMA scan that was not identified on the CT scan and would not have been treated in conventional radiation fields. This allows us to actually to treat the perirectal node and also dose escalate it to improve the chance of curing this patient. In the third case, we see that there was nothing evident on the CT scan, but there is a left pelvic sidewall lymph node on the PSMA scan, and we were able to dose escalate this area with our radiation, increasing the chance of cure. So if you look at one of the pitfalls of PSMA scans, it's renal excretion of some PSMA agents, which hinders accurate visualization of recurrences, both local recurrences and lymph node recurrences. And this is due to homogeneous bladder activity, as you can see in these examples. And also, ureters have a tendency to pool urine, and this can show up in the ureters. And this can have a great impact on how we interpret cancer versus urine activity. Of note, these are normal body distribution scans and are not part of a head-to-head comparison study. So another pitfall is both bladder and urethral activity. So if you look at these images and you look at the red arrow, is this uptake on the PSMA scan, is that due to urine activity or is that due to a local recurrence? I cannot tell based off of this scan. I would have to order additional imaging like a CT urethrogram or a MRI to convince myself that this was a local recurrence. Also, periuretic activity, the lymph nodes in the lower abdomen and upper pelvis run along the ureters. So if there's increased ureter activity, it makes it very difficult to discriminate the ureter from involved lymph nodes. So what are potential approaches to reducing the renal excretion problem? You could give Lasix to speed up the excretion. Alternatively, you could do large delays in scanning or multiple scanning times that are not feasible in a busy nuclear medicine department. Or you could use additional imaging like MR or CT urography, which is both expensive and delays the management of your patient. This is an example of a CT urography that improves discrimination between radiotracer activity and cancer. It assists in the interpretation of about 20% of cases. And if you look at panel B, you see increased uptake in this nodule right here on the PSMA scan, but you also see contrast in this object. So this is clearly not an involved lymph node, it is a ureter. On this panel C, you see a nodule with increased PSMA uptake, and there's no IV contrast in this area. So this is clearly an involved lymph node. In panel D, you see increased uptake on the PSMA scan in the distal urethra, but you also see contrast in the distal urethra. So this is clearly not a recurrence. This is just urine activity. So this was a very helpful scan for this patient. Now, renal secretion is an important problem because clinical trials such as oligopelvis, which is described here, are currently evaluating the benefits of high-dose salvage radiation, 72 gray and 36 fractions to the local recurrence, and 66 gray and 30 fractions to lymph node recurrences. So if you misinterpret a lymph node or a recurrence as, as a ureter or a bladder as a recurrence or a lymph node, then you're going to dose escalate there and you're going to cause bladder injury or urethral stricture, with both are significant complications. This is even potentially a more worrisome problem in oligometastatic disease trials such as STOMP that treat involved abdominal pelvic lymph nodes to very high doses, 30 gray and 10 fractions. This would put our patient at great risk of ureteral injury. So misidentification of a ureter as an involved lymph node places the patient at risk for morbid ureteral stricture. And how can we limit this risk? So one potential solution is reducing bladder activity with posluma. In clinical studies, low activity in the bladder improved tumor to background ratio and may enhance confidence in image interpretation in the prostate bed and surrounding tissues. The appropriate time to do a posluma image is approximately 60 minutes. This is where there is low bladder activity and low ureter activity. So 60 minutes is the appropriate time to do a posluma scan. And when you compare bladder activity in posluma scans through comparison across studies reported in the literature, posluma showed lower bladder activity compared to other renally cleared PSMA agents. No, this is not a cross-study comparison. Cross-study comparisons should be treated with caution due to differences between study populations, study methods, and et cetera. But this is some data that is hypothesis generating to suggest that posluma may be a very good scan if you're trying to discriminate cancer from urine activity. I'm very excited about recent work from Ko et al. That he presented at SNMMI in 2023, and he showed that it was possible in 96% of patients by majority read to distinguish between urine activity and disease activity. Finally, I would like to end with that I've been a practicing radiation oncologist for 20 years. From my experience, misinterpretation of ureter or bladder as tumor can lead to significant injury in the ureter and the bladder. Care should be taken with PSMA scans, and reduced uptake in the bladder and the ureter will reduce the risk of future injury of patients. I look forward to answering questions at the end of this session. Thank you.